Alright guys, today we're going to be covering Chapter 20, Acute Diabetic Emergencies. In this chapter we're going to go over what exactly diabetes is, or also known as diabetes mellitus. We'll go over acute diabetic emergencies that we will see in the field, as well as how to assess patients that are having a diabetic emergency, as well as alter mental status in a diabetic emergency. The mental state of a patient can range from disorientation to complete unresponsiveness during a diabetic emergency. Significant deterioration of the mental status from acute diabetic emergencies can lead to severe airway and breathing compromise. Brain cell damage and death can also occur if the blood glucose reaches a low level. Acute diabetic emergencies can include hypoglycemia, in which the blood glucose level is too low, or diabetic ketoacidosis, or hyperglycemic hyperosmolar syndrome, which we will discuss later, in which the blood glucose level is excessively high. Long-term complications of diabetes can include vascular disease, which ultimately leads to stroke, heart attack, and peripheral vascular disease, kidney disease, nerve dysfunction, and retinal nerve disease, which would eventually lead to blindness. Under normal circumstances, hormones control the blood glucose level. These hormones is known as insulin, and they are released by the pancreas. When a patient has a diabetic emergency, it is due to the body no longer able to control the blood sugar level or the blood glucose level because of abnormalities of the pancreas. Glucose is a major source of fuel for the cells. Maintenance of the glucose level in the blood is crucial for the normal function of cells. Some cells can use fats and proteins as energy sources if little to no glucose is available within the blood. However, brain cells cannot use anything but glucose. The brain cells cannot make glucose, they cannot store glucose for more than a few minutes, nor can they collect glucose into concentration from the blood. As already noted, the consequence of a lack of glucose to brain cells for a short period of time is brain cell dysfunction. When a patient's blood sugar level begins to drop, the brain is the first thing that's affected. They'll start having confusion, altered mental status, and then eventually go to the point that they go completely unresponsive, and to the point that where the brain cells themselves will begin to die, and the patient will continue to deteriorate. If a large amount of glucose moves across a membrane, a large amount of water tends to follow. This is one reason why a high blood glucose level is dangerous and proven to be detrimental in patients with a head injury or stroke. By having glucose, the brain allows more glucose to cross into the cells, and the glucose brings water with it. This could potentially cause brain cells to swell, which leads to more edema or swelling within the skull, which will then worsen the head injury or stroke. High glucose levels can also cause a patient to become dehydrated by that same premise. Because as glucose is excreted within the urine, it draws the water with it, which can eventually cause the patient to become dehydrated very quickly. Now, insulin is that hormone that I've been talking about. I like to think of it kind of like as a bouncer at the club, because it has three main functions. It allows the movement of glucose out of the blood and into the cells. So think of the bouncer at the club door. It allows glucose, them being the club patron, to enter the club or the cell. Insulin can also cause the liver to take glucose out of the blood and convert it into glycogen, which is glucose stored. It can also cause a decrease in the blood glucose level by the actions just listed. facilitating the movement of the glucose out of the blood and into the cells in the liver. Now, insulin attaches to the cell at a specific site, or receptor site, and causes another channel on the cell membrane to open. A protein then carries the glucose into the cell through this channel. Now, glucose can cross the blood-brain barrier readily. It is not dependent on whether insulin is present or not. So as I said, let me get my pointer. Insulin attaches to the receptor, then allows for the channel to open. So now glucose can enter. The glucose is now metabolized within the cell. If pending oxygen is available, it goes through aerobic metabolism and ATP, or energy, is released. If insulin is not available, the cell glucose moves into the cell at a rate approximately 10 times slower, thus causing glucose to build up within the bloodstream. Glucagon, this is what's secreted when the blood glucose level decreases to approximately 70 or lower. The major functions of glucagon: it converts glycogen stored within the liver back into glucose and releases it into the blood. It also converts other non-carbohydrate substances into glucose within the liver, and it increases and maintains the blood glucose level by converting glycogen and other substances into glucose. This is a hormone that is naturally released within the body, but once you move into the advanced and paramedic level, you can actually give glucagon as an IM injection to help facilitate this action. Epinephrine also plays a role in the blood glucose level, because epinephrine stops the secretion of insulin and promotes the release of stored glucose from the liver, as well as the conversion of other substances into glucose. And this is what causes many of the signs and symptoms that you will see in a patient with a low blood glucose level, because of the release of epinephrine. Which, once we start going over the signs and symptoms, you'll have a better understanding of. Now, the normal range of a blood glucose level ranges from 70 to 120. Within 1 hour after a meal, a person's blood glucose level increases to about 120 to 140 milligrams. When the blood glucose rises, it triggers the pancreas to secrete insulin, which is then released from the pancreas and immediately begins to increase the movement of the glucose into the cells. About 2/3 of the glucose within the body is taken up by the liver, which then converts it into glycogen to be stored by the liver and muscles for later use. The brain takes up as much glucose as it needs without the aid of insulin. As the cells continue to require and use insulin in the hours after a meal, the blood glucose level steadily drops near the lower end of the normal range. The pancreas then recognizes this decreased blood glucose level and then secretes glucagon. Glucagon causes the liver to begin converting the glucagon back into glucose and releasing it into the bloodstream. Other non-carbohydrate substances are also converted into glucose, thus raising the blood glucose level and maintaining it at a normal range until the next time you eat. So as you can see, this is it in a graph. So normal glucose, this is someone without diabetes. They eat their meal, sugar goes up, insulin secreted, cells uptake glucose, blood sugar drops, glucagon is then secreted, allows the blood glucose level to increase and maintain it at a normal level until you eat again. Now, when a patient has diabetes, there's a disturbance in the metabolism of carbohydrates, fats, and proteins. The primary problem in this condition is either A, a lack of insulin secreted by the pancreas, or B, the inability of the cell receptors to recognize the insulin and allow glucose to enter at a normal rate. Now, to check a patient's blood sugar, we use what's called a glucometer. Now, blood glucose is measured in milligrams per deciliter. The body normally maintains blood glucose levels within a wide range from 70 to 140. The specific level within this range depends on the last time the patient ate or drank, especially carbohydrate-containing foods and drinks, and other factors such as exercise and diet and activity. Now, fluctuations within a normal CBG or capillary blood glucose, because that's what we're measuring, range are generally considered normal and not expected. Now, a reading less than 70 can indicate a lower than normal level of glucose, whereas a reading greater than 140 could indicate a higher than normal amount of glucose within the blood, or hyperglycemia. Now, to test a blood glucose, you should test this before you administer any oral glucose or sugar-containing solution. What you do is you take your glucometer. You should check, make sure you have everything. You should have your meter, your test strips, which there's already one in the meter as well, your lancet or a lancet device, and alcohol swabs. First thing you're going to do is you're going to take your alcohol swab and you're going to clean the finger. You're going to clean the site that you're about to prick. You'll then take your lancet, and you'll make a small penetration into the skin to allow a drop of capillary blood to form. To get an accurate glucose reading, you need to get a good blood sample. So waste the first drop of blood onto a dressing. That'll also clean off any remaining dirt and alcohol, and then get a second drop onto your test strip. With the test strip, you don't have to do anything. All you got to do is get the yellow or the actual test strip up to the blood drop, and it will draw it into the strip. Shortly thereafter, usually within a few seconds, you will get a numerical reading based off the sample. Now, if the blood sugar is too low, it will flat out say low. Usually they're as sensitive to read to within 5 to 10 milligrams. Depends on your glucometer. It's the same way on the high side. Usually your glucometers will read up to about 450, 500. Some maybe a little bit more, but that's on a rare occasion. And if it's a sugar level greater than that, it'll just simply say high. Now, if there is no insulin or a minimal amount of insulin within the blood, the cells take up glucose at a much slower rate. Or if there is enough insulin but there is a deficit in the cell receptor sites that prevents them from recognizing and attaching insulin, this can also cause a drastic reduction in the amount of glucose that is allowed to enter the cell. An excessive amount of glucose collects in the blood and raises the blood glucose level. Because the glucose cannot enter the cells at a normal rate, the cells begin to starve for energy and must use other sources such as fat. Even though the blood is filled with glucose molecules, they are not available to the cells for energy production. Now you have what's called the 3 P's of diabetes. Alright, you have polydipsia, polyuria, polyphagia. Polydipsia indicates that the patient is drinking more fluids more often than normal. Polyuria means that they urinate more often, and polyphagia means that they are eating. Now there are 2 types of diabetes. There's type 1 and type 2 diabetes. Type 1 diabetics are usually between the age of 4 to 6 and peak again about 10 to 14. These patients are also typically lean due to weight loss, and their blood glucose levels are extremely high if untreated. Type 1 diabetics also often have difficulty keeping their blood glucose level within the normal range, with the possibility of having too high or too low a blood glucose level. Type 1 diabetics are also much less common than type 2 diabetics. These are the ones that are born with their diabetes. They do not secrete any insulin at all, and you have to take insulin through a shot to regulate their glucose. These patients are also more prone to develop what's called diabetic ketoacidosis, or DKA for short. Type 2 diabetics usually do not need to take insulin. However, they do have to regulate their diet and exercise and take oral drugs to help the pancreas secrete more insulin or to make the insulin that is secreted more effective in facilitating movement of glucose into the cells. These patients are usually with the middle age, usually about 30, 40 or greater. They tend to be overweight, and they're also more prone to develop what's called hyperglycemic hyperosmolar nonketotic syndrome, or HHNS. Patients with diabetes typically have a high blood glucose level. Blood glucose that is randomly taken can be greater than 200, compared to that 70 to 140 in a patient without diabetes. They're also prone, due to the damage that diabetes causes, to various diseases and disorders of the blood vessels, such as heart attacks, strokes, and kidney failures. Hypoglycemia is the term for a low blood glucose level. This is usually defined as a CpG less than 70, and is the most common type of endocrine emergency. It is more common in type 1 patients than in type 2 patients. Hypoglycemia is the most dangerous acute complication of diabetes because it is because of the issues that it could cause. It is estimated that most diabetics experience mild episodes of hypoglycemia 1 to 2 times per week that usually they're able to treat on their own, and 30% experience a severe hypoglycemic episode annually. Hypoglycemia usually occurs because the patient has to take insulin to regulate their levels. This patient takes their insulin, but with excessive results. Usually, if they become hypoglycemic, usually they've taken their insulin, but they haven't eaten anything, or they may have taken their insulin and eaten a normal meal, but they decided this time that they're going to go for a walk or to increase their activity in some shape or way. When patients are taking insulin, it is very sensitive. It's based off of what their activity and what they normally eat. So if they do anything out of whack, it can cause extenuating issues. Now, type 2 diabetics can also suffer from hypoglycemia. Usually the oral medications that they take can cause the blood glucose level to drop too far, thus resulting in hypoglycemia. Because these oral medications do have long-lasting effects, the hypoglycemia can be prolonged or can reoccur if the patients are not monitored closely. As the blood glucose levels drop, epinephrine begins to secrete at higher levels. The effect of this epinephrine is to shut down secretion of insulin and to stimulate secretion of glucagon, which in turn converts stored glycogen and other non-carbohydrate substances into glucose. As a result, many of the signs and symptoms seen in hypoglycemia are associated with epi circulating within the body, such as diaphoresis, tremors, tachycardia, pale, cool, clammy skin, dizziness, all signs and symptoms that you would see by the release of epinephrine. They may also see weakness and hunger, as well as feeling a warm sensation. Once it gets to the point that the low blood glucose levels are starting to affect the brain, your patients will become confused, unresponsive, disoriented, in more severe cases even seizures, and hypoglycemic patients can also present with stroke-like symptoms, especially in the elderly. That's why for any patient that we see that have strokes, we go ahead and check a blood glucose level as well. The hypoglycemic patient can also present with bizarre or even violent behavior. And for this reason, the patient's condition could be mistaken for a behavioral or psychiatric disorder, head injury, drug use, or even alcohol intoxication. This is potentially a tragic mistake because hypoglycemia can be fatal if not recognized and treated quickly. Patients with long-term diabetes usually recognize their own signs and symptoms that occur when their blood glucose levels are decreasing and they are becoming hypoglycemic. Over time, the signs and symptoms of hypoglycemia might begin to change and they may not recognize this change. This can cause them to allow their blood glucose levels to drop significantly without any intervention until they suddenly experience hypoglycemia. Now, our care and management of this patient is ultimately depends on the patient's mental status. We categorize them in one of two ways. Are they unresponsive, unable to swallow, or unable to follow commands? Or do they have altered mental status but they're responsive, they're able to swallow, and they are able to follow commands? For patients who are unresponsive, unable to swallow, or unable to follow commands, we want to administer oxygen via nasal cannula, pending O2 sats are less than 94%, with signs or symptoms of respiratory distress or hypoxia. If the patient is breathing inadequately, provide positive pressure ventilation. For these patients, you also want to contact advanced life support. The reason being is these guys, ALS, if they arrive on scene, because they can administer glucagon or what's D50 to boost their blood glucose levels. Remember, severe hypoglycemia can result in brain cell death. Therefore, it is critical to quickly get glucose to the patient's brain cells. Be sure to continuously reassess the patient's condition for improvement or deterioration and pay attention to their airway and breathing status. For patients who do have who may have altered mental status but they are responsive, they're able to swallow and able to follow commands, we want to consider administration of oral glucose. First thing we want to do is make sure that we have a patent airway, and then administer the oral glucose, which is the medication of choice for the EMT in emergency medical care of the diabetic with altered mental status. Be sure to continuously reassess their condition for improvement or deterioration, and pay close attention to their airway and breathing because you are putting a gel in their mouth for them to swallow. In cases in which all three criteria are not met, do not administer oral glucose. Instead, just provide emergency medical care for a patient with altered mental status and an unknown history. With oral glucose, it is absorbed very quickly within the mouth through the mucosal pores, thus increasing the patient's blood glucose level. If they... In some areas, we also have the option for what's called intranasal glucagon. Administering glucagon can raise the blood glucose level. However, its effectiveness depends on the amount of glycogen that remains in the liver for the glucagon to work on. If protocols allow you to use intranasal glucagon, administer the glucagon solution using a mucosal atomizer device and syringe. Intranasal administration of glucagon has been shown to have effectiveness comparable to that of IM and sub-Q glucagon administration. Now, this is not something that will take effect right away. This will take anywhere from 13, 16, even 20 minutes for it to work. This does not contain glucose. It is dependent on glucose stores within the body. Now, hyperglycemia is the term for a high blood glucose level and is defined as a blood glucose level greater than 200. Any hyperglycemic episode in a diabetic emergency should prompt the EMT to assess for an infection, acute medical illness, recent cocaine use, or medication non-compliance. If it does become more severe, it can result in either DKA or HHNS. Now, diabetic ketoacidosis. These patients will typically have an elevated blood glucose level greater than 350. What's happening is because of without insulin and glucose moving into cells, the cells are beginning to burn fat as energy for the cells. Now, this causes two problems within the body: dehydration and acidosis. The excess glucose from the blood begins to spill into the urine, drawing large amounts of water with it. The patient also then begins to urinate frequently because of the excessive glucose, simultaneously eliminating large amounts of water attracted to the glucose. This then leads to dehydration in the patient. Now, because the liver cells are not taking in glucose, the liver begins to metabolize fats for energy, which produces a byproduct called ketones. The ketones produce a form of strong acid. As the liver metabolizes more fat, acid levels within the body begins to increase to dangerous levels, thus causing acidosis. An altered mental status in the DKA patient is not from a lack of glucose to the brain, but rather it's a result from dehydration, fluid shift, and acidosis affecting the brain cells. The patient suffers from let me backtrack. There are multiple factors that can lead to a patient to develop DKA, such as the patient suffering from an infection such as a urinary tract infection or pneumonia that has upset the insulin and glucose balance, especially in the elderly or debilitated patient. The patient has taken an inadequate dose of insulin or is not compliant with their medication used to treat the diabetic condition. Patient takes medications such as thiazide, Dilantin, or steroids. Or they have suffered some type of stress such as surgery, trauma, pregnancy, or acute medical conditions such as a heart attack or stroke. Or the patient has had a change in diet in which they have overeaten or increased their carbohydrate or sugar intake. Many children will be in DKA the first time they present with diabetes. They will have no history of having diabetes, however, they will be exhibiting the signs and symptoms of DKA. These patients, no matter their age, if they are developing DKA, will have signs and symptoms such as the 3 Ps, the polyuria, polyphagia, polydipsia. They'll have tachycardia. They'll have what's called Kussmaul respirations, where they're taking very rapid and deep respirations. They'll also have what's a fruity breath on their smell to their breath, and that's because of the ketones being blown off. They'll have a blood glucose level greater than 350. Possibly also be having abdominal pain, warm, dry, flushed skin, and in the very late stages of DKA, even be comatose. Kussmaul respirations are a pattern of deep and rapid breathing that is commonly seen in the patient with DKA. It is an attempt by the body to blow off carbon dioxide to reduce the acid load within the body. Carbon dioxide produces another form of acid called carbonic acid. If the patient can blow off large of carbon dioxide by hyperventilating, those deep and rapid breathing, they can then reduce the amount of carbonic acid and thus reduce the total amount of acid within the body. The patient with DKA is typically dehydrated and acidotic. Thus, the treatment is aimed at reducing the blood glucose level and rehydrating the patient. So it may be prudent to contact ALS to begin rehydration in the field. And now, your care as a basic EMT is to establish and maintain a patent airway. If they make sure that they are oxygenating properly. If they are not oxygenating properly, such as having O2 sat less than 94, respiratory distress, hypoxia, place them on oxygen. If they're not breathing adequately, provide positive pressure ventilation. Check your blood glucose level. If it's less than 70, administer oral glucose pending the patient can swallow, and contact medical direction for further orders. Now, with hyperglycemic hyperosmolar syndrome, or HHNS, the pathophysiology behind it is similar to that of DKA. Now, this HHNS, or hyperglycemic hyperosmolar syndrome, has two other terms that you might hear called by: hyperglycemic hyperosmolar nonketotic syndrome and nonketotic hyperosmolar state, or NKHS. Now, to make it easier, I'm just going to stick with one from here on out, and I'm just going to use HHS. All right. With HHS, this is more common in the patient with type 2 diabetes. This is because the type 2 patient's pancreas can continue to produce and secrete some insulin, so some glucose is still getting into the cells. The glucose entering the cells keeps the amount of fat being metabolized by the liver to a lesser amount than is seen in DKA. That's why you don't have the ketones being produced and you don't have the fruity smell. Now, the patient will present with the signs of significant dehydration but with no signs of acidosis. Their mental status may also be altered because of dehydration of the brain tissue and not because of acidosis or lack of glucose. HHS patients are also more likely to have seizures than hypoglycemic patients. HHS carries a high mortality rate because of the pre-existing comorbid factors or conditions that have already existed before the hyperglycemic episode, along with a severe state of dehydration. Like the DKA patient, the HHS patient needs to be rehydrated with fluids. It might be necessary to call for ALS for this purpose. Follow your local protocols to determine what decisions to be made. Signs and symptoms that you will see are similar to those of DKA, such as the tachycardia, potential fever, positive tilt test, going through the 3 Ps, dry, warm skin, nausea, vomiting. But there will be no, like I said earlier, there won't be any ketones produced within the body, so there won't be no significant acid loads, so no Kussmaul respirations or foodie odor on the breath. Care for patients in HHS is basically the same as for DKA. If you are unsure or if your protocol does not permit you to attempt to distinguish between hypoglycemia, DKA, and HHS, treat the patient as if they are hypoglycemic. So even if you're unable to obtain a CBG, because you may be having equipment issues, you may not have it, go ahead and administer the glucose. If you make it higher, it's not going to cause any further worsening of the patient's condition. So just go ahead and administer it. It'll eventually go away. Table 20-2 goes over signs and symptoms of patients and with various diabetic emergency conditions. With DKA and HHS, it'll take several days for it to begin, whereas hypoglycemia is very sudden. Blood pressure when DKA and HHS are low, whereas hypoglycemia it's normal. The oral mucosa in DKA and HHS will be very dry, whereas in hypoglycemic patients they're salivating. With their blood glucose levels in DKA, it'll be over greater than 350. In HHS, it will be greater than 700. And in hypoglycemia, it'll be very low and less than 70. Care of the patient, basically, it's all the way across the board. It's supportive care. If you have a hypoglycemic patient, they're able to. You can give them oral glucose. Now, ultimately, with DKA and HHS, the patient is going to need insulin. Now, let me go ahead and say this. EMS personnel cannot administer insulin, period. Even if it's your partner's insulin, or if your partner's diabetic and he has, he takes insulin and he knows how to give it, or you're diabetic and you know how to give insulin. You cannot give insulin. If you give it, you will lose your license. We are not allowed to give it. The reason being is we don't, if it's high, if all of our glucometer says it's high, we don't know exactly how much to give. All right? So just don't give it. Let them get to the hospital. Let them administer it there. Now you want to look, when you're going through your assessment of a patient possible diabetic emergency, you want to look for clues gathered during the scene size-up, as well as during your primary assessment that could lead you to suspect that the patient can be diabetic. Look for medical alert tags, tattoos, or other medical identification that confirms a diabetic history. Now, I know in the previous chapters we said tattoos are not, approved for certain conditions, such as a do not resuscitate order. But if a patient has tattooed on their wrist diabetic, all right, I'll go with that they're possibly a diabetic patient. Okay. Insulin pumps is also included to a diabetic patient. With these, they will generally be very close by, possibly hooked to their hip, and they'll usually have a tube that runs into their abdomen that is pumping insulin into them at a continuous basis. Go through your sample history. It's important that we recognize the prescribed medications that a diabetic patient might be taking. Presence of such a medication can help to establish the history of diabetes. Look in their fridge because some of some types of insulin has to be stored within the fridge to keep it cool. Altered mental status from hypoglycemia can typically have a sudden onset, and the signs and symptoms will progress very rapidly over a period of 5 to 30 minutes. Ask appropriate questions, such as did the patient take their medications today? Did they skip? When was the last time they had anything to eat? Have they vomited any? Are they been feeling well? How long has the altered mental status come on? All of this can help you lead to try to figure out exactly what's going on. Consider the patient. If they definitely in the elderly, they're going to have signs and symptoms that mimic a stroke, such as hemiparesis. So that's, like I said earlier, look to see if they are what their blood glucose level is. They may even have an intoxicated appearance and where they look like they're under the influence of alcohol. You want to look at their abdomen because they may have bruising where they've been injecting insulin to. Also keep in mind that definitely with your elderly patients, they may be taking medications such as beta blockers that can hide the signs and symptoms of hypoglycemia. Because remember, hypoglycemic releases epinephrine should cause a rise in their pulse. Well, if they're taking beta blockers, it won't allow for that rise in pulse. Go through your care of the patient. Make sure that they have a patent airway. If they're not oxygenating properly, put them on oxygen to maintain an O2 sat of at least 94. If they're breathing inadequately, provide positive pressure ventilation. If you're able to, administer oral glucose and transport your patient. Go through, reassess your patient as appropriate. For criticals, we reassess how often? Okay, every 5. For non-critical? Right, every 20. Or excuse me, every 10. Now if you administer oral glucose, keep in mind that this could take upwards to 20 minutes for it to take effect, depending on how long it takes for the body to metabolize it. If after 10, 15, 20 minutes you do not see any improvement in the patient's status, consult medical control about administration of more glucose, but also start looking into other causes of altered mental status, such as sepsis, toxic ingestion of a material, hypoxia, something else that could potentially be causing it. Alright guys, that's it for this chapter. If y'all have any questions, be sure to send me an email in Blackboard or in Remind, or just write it down and ask it to me next time we're in class. Make sure you do the Brady Labs for this chapter. Otherwise I will see y'all in class.